start with, I think, as a community, as a collaboration of, profit, non-profit, all of us together, I think we take where we are at this stage today, if we go back to 2000 or 2001, and, if we looked at, if anyone gave us a scenario of 17 million patients, first line below 100 million, $100 per patient per year, much below $100, and second line below $250 per patient per year. I think, as a global community, we take it and, more than take it. So I think all this has been achieved, and it's not come easily. The capacity has been created, and there was a cost to creating capacity. If you look at all the companies, the manufacturers which contributed to this, I'm sure $500 million have been spent just on creating API capacity to treat these patients. And, if the problem with defining the ARV space as a business is, profit might be a bad word in this space, but then investment and profit go together. Investment comes out of profit. And you have to have a sustainable commercial business model to sustain 15 to 30 million patients. It's not going to come out of charity. So that's a very important understanding. It's something which, which people need to recognize, and that's what has delivered even the 16 million. It's not as if, 16 million has come out of charity or corporate social responsibility. It's important you make a commercial, sustainable return on your investment in this space. Second thing is, if you just look at some of these, some of the data, TLE today, just tenofovir, lamivudine, efavirenz, it's probably the single largest generic drug in the world, across any other drug in terms of volume. And the way it is bought, the way it is delivered, I'm sure there are ways we can improve it. If it is the single largest generic drug in the world, then we need to treat it, and from all points of view, as the single largest drug, and have better ways of managing it. Going forward, it might be the 400, it might be TAF, it might be dolutegravir, but if these are going to be 4 of the single largest combinations in the world, then we've got to find better ways of managing them. I also feel that 1 to 17 million patients is not going to be the same, the 17 to 30 journey is going to be different from 1 to 17. Procurement methods have to change, approaches have to change, things have to get more, frequencies have to change, things have to go more predictable. People can't afford to fail, people can't afford to, take each other for granted. We'll have to work together much more collaboratively in the future than we did in the past, if we have to move from 17 to 30, as we did from 1 to 17. And I think the most important thing is taking the focus away from the price point to the cost point. I think the new formulations will be there. The industry will deliver on TAF. They will deliver on dolutegravir. We will deliver on low dose of efavirenz. And this is the way to go. Cost is what we should talk about rather than the price, because price is a function of, who is willing to go lower. Cost is who is willing to put in the effort to bring the base down. So I think that's the direction in, which I'd like to take this discussion, on the cost rather than the price. And the incremental innovations are there. The 3 months pack, the 9 months pack, as you get smaller, the 6 months pack, as you get smaller tablets, you can give a 6-month pack. If you get healthier volunteers, you need not see them for 3 months maybe. So these innovations are possible, but then commercial interest has to be sustained. It has to be a commercial, sustainable business model, and only then it will work, this 30 million patients we're talking about. I think the last point, I don't know, I think the patients are also going to get harder to find. If I go to Nigeria, if I go in my country of birth, that's India, we're talking about this 17 to 30, but how difficult it is to move, the needle from, if you look at the coverage in Nigeria for the past 5 years, we're still talking about a 30% or 40%. So, finding the patients will be more difficult, and I don't know how. I really don't know the answer to, probably we can get it from our panelists in terms of, what methods we have to find more patients.
Thank you, Arvind. Your comment on the next lift from 17 to 30 million is going to be more difficult than the first lift. I'd like to come back to that later in the conversation.
if I think about what happened with HIV over the last number of years, I think a common theme, and I think it's been sort of reiterated in this conference, is the power of collaboration and the power of partnership. You know, the power of partnership between industry, government, implementers, funders, and academics. And I can assure you that industry is right up there as a partner. We've worked really well with everybody over the last number of years to be able to provide the commodities, to be able to get where we are today. But what's ahead of us is a huge challenge. And we do have to work together, and we have to innovate together. When we look at 1990 from our perspective, by both being a resident of Africa and travel, I'm probably one of the only executives that really still want to go to the coalface, to the rural areas in Africa, and really see what happens there, because that's where I believe your strategy has to come from as a global company. And, you know, when I look at Africa today, we still live in an Africa where 60% of our population lives in rural Africa. And if we look at where we are at the moment with 1990, I think if you cascade that down and look at where are we with 1990 in rural Africa compared to where we are with 1990 in urban Africa, I think the situation is much worse. So we need to be able to bring diagnostics and healthcare to rural Africa. And I believe the only way that we can do this to reach scale is to really go down the healthcare pyramid to primary healthcare. So this is an area where we have invested in innovation a lot. You asked the first question on screening. So yes, it's true, there's been little innovation in screening over the last number of years, but lately we have now a fourth generation rapid diagnostic that is very, very close to the performance of your fourth generation laboratory tests that could be rolled out. And I think especially when it comes to test and treat and really increasing case finding, you know, to get to that first 90, I think it will play a very important role. We also have now diagnostics where an HIV test could be combined with some other disease states. You know, and a good example of that is by screening for both syphilis and HIV simultaneously in one test. But as we heard from some of the other panelists, data is very, very important for us to be able to get to 90. So one of the things that we have to overcome if we want to go down to primary healthcare is we need to get real-time data on things like consumption of commodities. So a lot of innovation have come through the power of the mobile phone. So today we can have point-of-care diagnostics that can be connected via a modem, and data on consumption can be collected in real time and transmitted to central planning warehouses. And then you can obviously put the inventory on site in there. As you do the tests, it basically takes real-time data on how you use the tests. And then you can predict stock-out dates, and you can predict resupply dates. And you can also look at your entire country or your entire region and really prioritize areas where you need to supply first. So this is a sort of innovation where I think industry and government and implementers can really work actually much better. In the future, we will have rapid screening readers that will work off a mobile phone so that we can also start to track, you know, rapid tests and the use of rapid tests. And then when we move to that last 90, when we look at viral load monitoring and making sure that all our patients that is on treatment is virologically suppressed, we see now that viral load point-of-care testing is becoming a reality. We have devices now for early infant diagnosis that have actually come through the WHO pre-qualification process that is available for procurement. And these devices, by the way, have also been linked up with these connectivity networks. So for the epidemiologists, you would be able to see what is the community viral load in a specific region, and is interventions bringing down community viral load. So we'll be able to track much better, whether the strategies that we employ is working effectively, and we will have data available, in almost near real time. I think this will inform the strategies moving forward, when we look at tackling the disease and making an end to AIDS by 2030.
Thank you, Willem. This discussion started at the policy level, has moved through the global level, and now you brought it down to the site level in country. And Iain Barton is our next speaker, and his company works at that in-country supply chain level. I think in Nigeria alone, they're distributing products out to 6,000 sites across Nigeria.
And I've been scribbling furiously as we've been listening to the speakers, and I can tell you that the things I'm going to say are not what I prepared last week, because there's been a lot that I've been listening to over the last 3 days that really have changed the way I'm thinking at the moment about what we need to do. The one thing that's absolutely clear is that what got us here will not get us there. We're going to have to do things differently. We're going to have to do things with a lot more innovation. And innovation is a great concept, it's a great idea, but it comes with a whole impact for those of us who are the investors in these things, because if the methodologies change quickly, that means that your investment becomes defunct. And so your cost versus price issue is a very, very interesting one as we see technologies, especially around test and treat and treatment site level testing. You're going to see very short life cycles in some of the products and the services that are being exhibited in those tents down the back there. So my own thoughts on where this thing's at. The 90-90-90 concept, I'm a great supporter of, and I think it really has changed the way that everybody's thinking. It does presume the fourth 90, though, and that is the prevention aspect. And I don't know that the 90% of people who are positive knowing their status actually gets us as far down the road as we're going to need to go in terms of prevention. But the recurring themes that I've heard over the last few days are really the ones that have started to scare me a lot, because I think we've done the easy bit. I think getting to 17 might actually have been the easy bit, and getting to 30 are going to be the hard yards. Because when you start talking about key affected populations, and you start talking about what effectively are hard-to-find patients and hard to manage population groups, and you listen to somebody like Mark, who is incredibly well-informed, talk at that South Africa event last night and saying that South Africa does not have a single epidemic. South Africa has a myriad of micro-epidemics, and each of them will require a different method of response and a different way of management. You start to realize that what we're going to have to do as supply chain practitioners is some serious segmentation of our strategies and some seriously sophisticated models of management of those different communities. And we're going to have to really start thinking about what's become known in the private sector as patient-centric supply chain systems. We're going to have to take a lot of the learnings that we're using in the private and commercial business and bring it into this public health space a lot more than we have. The containers discussion is a really interesting one as well, because that's the bit we've always thought of, because it's the way that we were able to express the impact to the policymakers and the funders, is that there's this visual impact of the 35 containers a day. But there's then the next step, which is, so does that mean your number of warehouses has to grow linearly? Because if it does, we don't have enough warehouse space at the moment for the way we're doing it. So that means we've got to double the number of warehouses as well. But nobody's going to have enough money to do that, and nobody's going to have enough people to maintain that. So the only way we're going to get that out of the picture is if we change the way we do downstream supply. We've got to increase the velocity through the supply chain. We're going to have to radically change the way in which we do the downstream delivery. Because only if we increase the frequency of delivery downstream can we increase the velocity through the warehouses and thereby reduce the number of warehouses we need to build. So it's going to need us to move our focus away from just the containers on the water, not even just into the warehouses and the sheds, but into the way in which we drive delivery and the way in which we force care and treatment sites to integrate with the supply chain and give us the information we need to do that effectively and fast. So it's going to be about that inverse proportional relationship that exists between scale of warehousing capacity versus frequency of delivery. Good, simple supply chain practice. It's not rocket science, but it is a whole lot of behavior change and a whole lot of downstream education that we're going to have to do. And just in terms of the way that I think we'll get there, I think one of the most important pieces is that it's going to take an immense amount of collaboration. And one of my things of the moment is we need to stop. In public health, we spend an awful lot of time debating the 15% on the fringe of stuff that we don't agree on, instead of actually concentrating on the 85% of stuff that we do agree on. And yes, good academic debate is a powerful thing, but it needs to happen in that environment. Once we get out into practical application, let's focus on the 85% we do agree on and get it done. So the collaboration is going to be vitally important. And then the last point is that we're going to have to look at the way in which we do this operationally. Governments and donors are going to have to change the way in which they spend their money. Stop spending money building warehouses and buying trucks, and start spending money with people who own trucks, and start spending money with people who own warehouses and are willing to invest in warehouses and trucks. And that means engaging effectively with the private sector. And to do that, we're going to have to drive the psychology of VAN, or Visibility Analytics Network, of changing the policy, changing the philosophy. That's the fourth P, I think, that should have been in the VAN blueprint. It should have been changing the philosophy of people, changing the policy that allows confident and robust integration of the way in which the public sector then gets involved with the private sector, so that we can build the capacity of people, point the people at the right areas with the right skills, and then put in place those changes in behavior, those changes in process that will get us to deliver the product. But then comes the S of VAN, and that's systems. And there's that famous Bill Gates thing of electrification amplifies. If we haven't fixed the processes and we stick in IT systems, we will make bad processes worse. But if we've actually perfected the others and we then stick in great systems, we'll be able to do things well. And just, Gavin, this idea about integrating testing data with SVS, with the stock visibility data, to be able to better inform supply plans, I think it's a great concept. But if we don't get to that level of sophistication quickly, we're never going to be able to inform the kind of scale that we need to achieve.
So right now we're at the in-country level, service delivery, the 90-90-90 challenge, the new WHO guidelines, differentiated care, cascades of service are really could potentially transform what happens at the ground level.